And my next guest has written about a topic that I think is extremely important and not well understood in the whole debate around healthcare. So she's been on the show before. I always appreciate what she has to say about healthcare and other topics, and I thought it was well worth bringing her back for this. Natalie Shure is the head researcher for Adam Ruin's Everything on True TV show. She also is a freelance writer who covers health as well as other topics, politics and related issues. She's written for Jacobin in these times and other publications, and she joins us once again now. So Natalie, thanks for coming back on the program.
Thank you so much for having me.
Secondly, your piece is called, it's in these times, and it's in the print edition. It's called, the headline they gave it, we don't always pick our own headlines. Headline they gave it is, "Yes, we're coming for your private insurance plan. Does Medicare for All mean abolishing private insurance companies?" So tell us, does it mean coming for your private insurance plan?
It absolutely does. There's a big debate going on right now about whether or not we can or should abolish the private health insurance industry as we know it. And my argument is that that is absolutely necessary to build the just universal system that we need, especially in an American context.
So let me give you, by way of not arguing with you, let me give you a statistic which you may or may not have marshaled on behalf of this argument. Medicare Advantage is the private insurance alternative to regular Medicare. And they get people in certain ways, certain promises once a person qualifies for Medicare. So the government inspector general took a look at Medicare Advantage denial rates. And it turns out that Medicare Advantage, which are private insurance plans overlaid on Medicare, overruled their own denials on second review 75% of the time, meaning that for people who applied for a treatment, for authorization for a treatment, which is part of what private insurance does, they broke the rules 3/4 of the time. And a lot of those people just went away and didn't get the care they needed and the care that their doctor prescribed for them. So that to me suggests that even in Medicare, where private insurance has been maintained and encouraged, it's predatory and keeps people from getting the health care they need. Agree or disagree?
Yeah, I agree. If I'm not mistaken, the report that you are discussing also found that in a lot of cases, these claims denials were done for specifically profit-driven reasons. And of course, that makes a lot of sense. That's why these companies exist. That is the business mandate they have. And that's exactly why we need to eliminate them and have another entity playing the role that they currently play in financing our healthcare system.
So let's get into another aspect of this then, because I find that particularly with the political vocabulary being what it is in the media, that when some people hear those of us on the left saying eliminate, ban, whatever, people get really, certain people get really upset, and it sounds totalitarian and it sounds unreasonable. Let's start with this. The Medicare for All bill that Representative Jayapal has introduced, why would you even need private insurance? Because the treatment that you need is covered. Things that aren't covered or well covered now, like vision, dental, mental health, are covered. No co-payments, no deductibles. I don't even get what private insurance would do if you have a system that's comprehensive and humane like that proposal.
Well, I think that's absolutely the right question to ask, and that's certainly the question that I ask: what value does private insurance even bring to the table? And frankly, the answer is that it doesn't bring any value. Right now, as far as I can see, the chief argument for it is the fact that it already exists, and that's just not good enough. I think that, in the Jayapal bill specifically, any role that there is to be left played by private health insurers is, a very minor one, that it might have, something to do with, if you want special supplementary coverage, things that are, not medically necessary. Other countries have that as well, where you can get, small things that are not medically necessary on a strict basis, that there might be some role for private insurance there, but it will not play the dominant role that it does in our healthcare system now.
So are you really, what are the other theses of your piece that maybe we've neglected up to now? What else do you argue in these times in terms of abolishing private insurance companies? What are your other arguments? Any others we need to cover before we go on and talk about some of the permutations of this politically and otherwise?
Yeah, I think that there are a few big ones. One important one that I think gets missed when people talk about, what if we preserved a role, or what if we had Medicare or an expansion of Medicare for some people who want it and left others on employer-sponsored or private health insurance. The problem with that argument is that that precludes Medicare for All's ability to do the things that it does best, which is make sure that everyone's covered, do so without copays and deductibles, eliminate a lot of the administrative waste that happens in our system. One reason that our system is so expensive is because the multitude of payers, of different types of plans, of different types of providers that pay different rates to different different insurers paying different rates to different providers, that kind of thing. That takes so much administrative work on the provider side and on the insurance side, and that Medicare for All allows you to reduce that by a lot. And that's not something that a system that retains a role for private health insurance, or for that matter, a system that retains a role for private health insurance and adds a public option, that situation is not fixed in that scenario. And so having no private health insurance allows you to achieve the administration reductions that you need. It also makes sure that the government, the single public payer, has the bargaining power that it needs to control costs in the long run. The fact that no single entity in the U.S. system has enough bargaining power to set rates means that there's a ton of bilking, that there is no real check on a provider's ability to charge, and that there's rampant inflation across the board at every level, which is how we get numbers in the U.S. system that other countries don't see. Those are two hugely important things that can't be done with private health insurance, not to mention just the automatic coverage of everyone, which I think is the most important thing that single payer Medicare for All provides, that can't be provided in the same way outside of that mechanism in most of the plans as they're presented. So I think that those are a really huge deal. The other thing that I think that people overlook when they're talking about private health insurance and the role it plays in other universal systems is that in the US, our health insurance system didn't grow from a social insurance model the way that, the German system, for example, did, where there's a nonprofit, a bunch of competing nonprofit entities paying for care for the people who are a part of it. That's something maybe closer to, I want to say, the Social Security. Social Security is obviously publicly run, but the way that it functions, that people pay into it and it pays out. Our insurers operate on more of a property insurance model, the way that if you have a car or a house and you pay a premium to pay in the event of a disaster, that's really how our insurance are structured, that for-profit property insurance model, which is really a disastrous way to pay for healthcare. It's especially bad and especially dangerous for people who use healthcare a lot, people who have chronic illnesses. Women use more healthcare than men, particularly in their reproductive years, and other people who end up, with diagnoses that make them require more healthcare than the average person. This for-profit property insurance model is particularly disastrous for them, and our private insurance system doesn't really have an answer for that.
I think you've touched on something, a couple things that are super important there. And one of them is, I usually don't do this. Actually, in last week's show, I talked a little bit about my own personal experience with it because I have a long-standing, relatively mild, but a long-standing hearing disability. And for some reason, our system doesn't want to cover things like hearing disability, and hearing aids are insanely expensive. So you have the choice of, being, as I was when it was originally diagnosed, a young person who misses, 30, 40% of life, and they're now discovering, cognitive, neurological problems that result and so on, or going into debt or, spending huge sums of money. So we have these weird pockets, these weird gaps. We are not designed, as you say, to cover chronic health conditions, to cover the health conditions of women. But the origin story of our healthcare system is also really important, and I want to get into that in a second. The way I want to do it is by talking about the fact that you will hear people say, including self-proclaimed wonks in journalism and elsewhere, well, you people want single payer, you people want to get rid of private health insurance, but even Great Britain has a private healthcare supplemental system, and you can get private health insurance of a kind in Canada. So why can't we do it here in the United States? And I have some thoughts about that, but I'm sure you've heard that argument too. And what's your reaction when someone says that to you?
Well, it really depends on what country they're evoking, but I think that the answer for me tends to be the fact that they bring up, these other countries have this, why can't we have that? Generally speaking, those are shortcomings of those countries' systems. Things like Canada does have a single payer healthcare system, much like the one that we hope to build here. In certain provinces, they don't cover prescription drugs in that system, and people have private coverage for that. But that's a massive downside of the Canadian system, not something to be emulated on purpose, simply because they have other forms of coverage in these countries. In something like the UK, there is a private insurance option, but it's relatively unpopular. And it's something that, providers are only able to do during off hours, I want to say. So, these are really functioning in entirely different ways in these other countries. And I wouldn't say that they're functioning positively, or that there's something good to point out in these other systems.
Yeah, it's almost like saying, well, we should be able to administer Band-Aids on our system without saying, well, why do you want a wound in the first place? And there's another, I couldn't agree with you more, and I think there's another aspect of it which you touched on a minute ago that I also want to bring up, which is the kind of original sin of how our healthcare system came into being and how it's evolved over 75 or 80 years. It was really an aberration, right? Because wages were frozen for a period of time around the Second World War. Employers couldn't compete on wages. They started offering health plans, and then there were various political forces, not worth going into here, but we developed this semi-privatized employer-based system, which, by the way, gives your boss an awful lot of power over your personal life and well-being. And but one thing those countries don't have that we do have is 75 years of the profit motive perverting the behavior, I would argue, of insurance companies, of for-profit practice management corporations, of big pharma, of for-profit hospital corporations. I would argue that the entire healthcare supply country in this chain has been polluted by runaway profit seeking, and that because we're sicker, we have to really clean the system out. And to me, that means getting the profit motive out altogether, because we've taken it to a perverse degree and it's simply intolerable. But I don't know, what are your thoughts about that?
I think that that's absolutely right. I think that, and even the fact that you point out, because we're sicker, that there's all of this rampant profit seeking, and that has so much to do with why prices are so high. I would argue that the profit motive in, not just healthcare and other basic needs in this country can largely explain why people are so sick. I think that inequality is a massive predictor of poor health outcomes in the United States relative to peer countries, especially. And that, a lot of that is that we don't have a significant welfare state. We barely have a safety net in a lot of cases. And, people are unhealthy, they're incredibly stressed out, they're living very precarious lives. And yes, a lot of the times that translates into needing more health care. After 75 years, there is a very deeply entrenched for-profit healthcare system. It's still going to have a lot of problems and a lot of inequities if we implement a single payer system tomorrow. But single payer at least gives us some of the tools to start addressing these, at least when it comes to the healthcare system. One of those things is, the fact that our system is currently so piecemeal and complicated. That's at least, the source of a lot of these price increases. Centralizing it, making it more cohesive, easier to participate in and understand, easier to run, even that in and of itself is going to help address some of these issues.
And again, we're talking with writer and researcher Natalie Shure about the role of private insurance in the American healthcare system and what role it should have going forward. Now, Natalie, I'm sure you know that one of the areas of debate around the Jayapal proposal, the Medicare for All proposal, is the notion also of global budgeting for hospitals, and the notion that hospitals should understand, what they'll have to work with going forward, and that we won't have the kind of fee-for-service system we have now. Do you have thoughts about that and where that fits into this conversation?
Yeah, I think that the beauty of global budgets is essentially that it allows you to create something that's, closer to an NHS hospital, that it basically precludes a hospital from gaming the system after Medicare for All is implemented by trying to figure out different ways to code different services, to, perform more services, to get better reimbursements. I think that global budgeting is a way of looking at a hospital and the people it serves and saying what is, a realistic way to operate this in a way that addresses needs, but can't be gamed, that can't be scammed as easily. And I think that, the conversation starts from there. So, I think it's a really exciting idea, and I'd love to see it advance.
I think a lot of people don't realize, Natalie, how much of a wacky sort of roadrunner and Wile E. Coyote system we really have now when it comes to medical billing, where you've got, the kind of roadrunner hospital thinking, well, or I don't know who's who actually in this example, but, you have the kind of Acme billing. If I add in a complicated diagnosis that has nothing to do with the admitting diagnosis, but a skin rash or something, discoloration, then the DRG coding changes and the reimbursement goes up. And if they stay a day longer than the prescribed, I lose money. But if they stay 3 days longer, it kicks into fee for service. I mean, I don't know what the current status is. I used to look at medical bills and do this, but it's wildly complicated and needlessly effort-inducing, and injects unpredictability, cost acceleration, even affects the care that people receive, sometimes in very negative ways. Surgical bills where procedures might not have been needed. I mean, just go on and on. We have this weird disconnect. We have this crazy Rube Goldberg billing system that sometimes, instead of serving to help people get the medical care they need and help providers, keep their lights on, seems to be driving the care instead of serving it. Do you agree with that?
Yeah, I think that, in the worst cases, that can definitely happen. I think at the very least, it's fair to say that, providers hate this system too. The fact that a lot of them have to figure out all of these billing codes, ways to upcode, new ways to, figure out intricacies of the ACA and the billing system to, get more reimbursement. I used the word gaming and bilking before, and sometimes I think that does have something to do with it. But, I think that very good actors are incentivized to do this as well. If you have a for-profit hospital or if you have a nonprofit one, there's a lot of pressure to economically perform, to show that can justify the resources being sent your way. And so, as long as this system exists, there's a lot of pressure to play by it. And I think that, doctors are more burdened than ever by paperwork and by administrative things that pull them away from their patients. Like I said, the administrative part of the healthcare industry overall is getting bigger and bigger and bigger. I think that there is so much room for, all types of negative impacts because of this system, and that, something more elegant, something simpler, something like global budgets allows hospitals and providers to focus on what they should be doing.
So let's talk for a second then about all the people who do all that work, because this is another something that always comes up in the discussion. And some people say it's 800,000. Some people say we don't know exactly how much, but our current cumbersome system employs a lot of people, a fair number of people, doing all the excess work that will be unnecessary if and when we have a rational system, right? So you have the question of a just transition for these folks. I mean, where I always start is, studies show that 45,000 people die each year because of lack of adequate medical care. And I think that's probably low when you consider people with insurance who can't afford copays and so on. But I mean, you would never say in a rational society, let's kill 40,000 people every year to employ 800,000. I mean, it's like The Lottery by Shirley Jackson or something. You wouldn't do it. So, yeah. Right? So that's number one. But beyond that, I guess, what are your thoughts on the people currently employed by the wacky system we have in place, and what can be done for them?
Yeah, I think it's definitely an important issue. I think that the importance is sometimes somewhat overstated, given, the number of people who are laid off per year in America is well over the number of people who would be displaced by this system. So I think that I'm not saying that's good, but I think that sometimes the relative size and importance of this group is inflated for political reasons. That said, most bills, including, I believe, Jayapal's bill, do include provisions for individuals affected by this displacement. I think that may in some cases come as a severance package. There are some training programs. There are, job placement assistance initiatives in some cases. And so that's definitely something that people are thinking about actively. I do have a lot of sympathy for people who will become displaced workers after single payer, but I think it's nonetheless important. And you're right that this is a matter of life and death, and we have to proceed as if that's the case.
Yeah, and I agree. And I think also when you start looking at the nurses and bill reviewers and other people who are part of this system, some of them would make great medical providers, and we're going to be giving medical care to more people. So whether it's as nurses or paramedicals or whatever, I think that a just and humane society can find work for them without sacrificing the lives and well-being of millions of people. So Natalie Shure, let's talk a little bit about the politics of all of this. For some reason, we're still we're changing, which makes me feel great, but we're still in the stage of the debate, particularly among insiders and pundits and self-proclaimed wonks and so on, where spending $32 trillion over 10 years through the government is considered shockingly costly, but spending 34, 36, 38 trillion out of people's pockets, taken regressively from those who can least afford it, is just business as usual. So, I mean, that's one of the big obstructions to getting something like Medicare for all in place, is that people say we can't afford it, even though we're spending more than that now, because of the psychology of spending through the government. Do you have any thoughts on how we combat that?
Yeah, I mean, I do agree. I think that the politics are going to be complicated, and certainly the medical industry is going to throw absolutely every resource that it can at defeating this. They've done that in the past, in the 1940s when it looked like national health insurance might pass. They tried to do that with Medicare. In a lot of cases, they tried to do it against the ACA until they were given enough carrots to, kind of stand down. So they're definitely going to fight it. What I find is interesting about the political debate is the fact that, left of center, as far as I can tell, pretty much everyone agrees that we have to do more than is in place now. We have to, push some leftward healthcare reform. I think that there are plenty of Democratic politicians who wouldn't want to go far as Medicare for all, but certainly want to expand the role of, public insurance. And, I think a lot of them are warming up to the idea that there need to be tighter regulations on the market, on the industry. Frankly, the industry is going to fight that too. So the political hurdles that you're talking about are always lobbed against Medicare for all and single payer specifically, which is very curious to me because they're going to fight all of these other systems just as hard. And so it seems to me that, if you're going to have to fight a massive uphill political battle either way, why would you not want, why are you preemptively compromising and kicking the can slightly further down the road the way that we tried to with the ACA? We're going to end up with the same problems because they're not really addressing the root of the issue, the root of the reasons that our healthcare system is so uniquely screwed up. And so I think that the political argument tends to be misapplied.
I couldn't agree more. And this is what I was going to say, what I sometimes call the friendly fire problem, but I've actually never called it that before. It just popped into my head. But so why would I say that? But anyway, it is kind of a friendly fire where people say, yeah, I really think I support single payer, but it's just not achievable politically right now. So I think instead we really need to stick with an extremely complicated plan that is very hard for people to understand or apply for or administer, and that gives them enormous out-of-pocket costs and leaves enormous areas of health treatment uncovered, because somehow incrementally that will get us to single payer. I don't understand how these incremental plans, which as you point out, are just as unpopular and going to meet just as intense a level of opposition, I don't understand how they even get us to where their proponents say they agree we need to be.
Yeah, I mean, in a lot of cases, a lot of the competing plans don't even result in universal health care. Especially some of the public options, some of the, Medicare buy-in plans, none of those have universal coverage or even portend to. The Center for American Progress plan, I will say, does result in universal coverage, but doesn't do anything to address the issues of underinsurance, which is, the tens of millions of people who have a plan but can't afford to use it because the deductibles and copays are so high. So they're effectually uninsured. A lot of these other compromise plans will face just as much opposition, but won't actually address the problems that we need to address in the way that Medicare for All does.
Well, and I remember these conversations around the Affordable Care Act when the debates were first going on, 2007 or so, and healthcare economists would say, of that, sort of sector would say, and it's still in the Center for American Progress plan, I believe, you should be able to pay 10% of your income on premiums, and then it maybe we'll throw in copays and deductibles too. But nobody who believes that, I believe, has ever tried to raise a family of four on a $65,000 a year income or $75,000 a year, because saying that, oh, here's another $7,500 in case you get sick that you should just be willing to do without if someone in your family winds up in the hospital is just not the way real people live. We have 50% of the population saying they couldn't come up with $400 in case of an emergency, 70% of the population saying they couldn't come up with $1,000. So any plan that says you have to pay pay out of pocket 10% of your income is automatically ensuring that millions of Americans will not get the health care they need. And yet that's the status quo for plans like that. So I guess the last thing I would ask is, do you have any thoughts about how we push back on that effectively so that we get real single payer?
I mean, I think, the important thing is that we know that historically, once we actually get these things, a constituency forms around them to really vehemently defend them. I think that these kind of concerns have been raised about every major public expansion, and, something like Social Security, which I think was considered, bridges and bridges too far at the time, is now such a bedrock of American society and American life that, no matter how hard neoliberals have tried to push back against it, it is, I mean, knock on wood, still intact. And so I think that, obviously that's putting the cart before the horse a bit, but I think that, seeing these objections for what they are, something that, comes up routinely historically and have been proven wrong again and again, should at least, galvanize the efforts of people organizing around this. I do think that pushing for it to be a litmus test, really being relentless about getting public officials to endorse certain things, to make sure that we address misconceptions, to, have public demonstrations for these things when it's possible. I think that all of those things will be very important, and that the common thread in all of them is to have, a really robust, vocal, ground-up operation demanding these things. That's going to be, I think, the key in making sure that they get pushed forward, to have a, really broad, on-the-ground constituency for these, so that it's not top down, I think is going to be instrumental in making sure that we get this over the finish line.
Well, I agree 100% and sign me up. So Natalie Shure, writer-researcher, head researcher for Adam Ruin's Everything on True TV, and freelance journalist. Thanks for your great work in this area, and thanks for coming back on the program.
Thank you so much for having me.